We took patients who supposedly failed topical therapy, and then we gave them topical therapy and they got better. This idea that topical therapy doesn't work, I think, is based on a misconception. It's based on our observations that it doesn't work, but we're not seeing how poorly compliant patients are. If we take people who failed topical therapy and do things to really get them to use their topical medication well, their skin disease clears up.
Welcome to episode 54 of Dermatology Weekly, the official podcast of MD Edge Dermatology, where we bring you the latest in dermatology news and peer-to-peer conversations with clinical and research experts in the field. I'm the voice of MD Edge Podcast's Nick Andrews. In this episode, we'll bring you up to date on the news from the American Academy of Dermatology to cancel the 2020 meeting in Denver in the wake of COVID-19. And coming up later in this episode, Dr. Vincent DeLeo welcomes Dr. Nwanneka Okwundu and Dr. Stephen Feldman to talk about strategies for promoting better treatment adherence for patients with psoriasis who do not respond to topical treatment. The peer-to-peer portion of our show comes with robust show notes available wherever notes are found in your particular podcast app. In the notes, you can find an outline of takeaways from the conversation as well as background information on Dr. DeLeo and our guests. We appreciate you listening to the show and thrive on your feedback, of course, so if you have thoughts on how we can improve or what you like, or if there's a topic or guest that we just have to cover, please email us at podcast@mdedge.com. You can also find us on Twitter at mdedgederm. And now, the latest in dermatology news. In this episode, the antifungal drug Terbinafine does not appear to increase risk among pregnant patients, and later, you can consider toys as culprits with children who have contact allergies. But our top story this episode, the American Academy of Dermatology canceled the AAD 2020 annual meeting in Denver in the wake of COVID-19 coronavirus outbreak. The decision was made in the wee hours of the morning on March 10th, 2020. Dr. George Hruza is the president of the AAD. He posted the following statement online in the wake of the decision. Quote, after carefully weighing the emerging facts as well as our duties to the Academy, our members, other meeting attendees, and the local communities we as dermatologists serve, the AAD has made the difficult but necessary decision to cancel the AAD 2020 annual meeting in Denver. We also want to respect our physicians' need to be available and healthy for their own patients, communities, and their countries. Dermatology and the AAD are not the only specialty in society affected by coronavirus. On the same day, the American College of Cardiology and the Society of Gynecologic Oncology announced respective annual meetings have been canceled. Dr. Hruza added that the AAD is looking into online and virtual options for the meeting. You can follow this story at mdedge.com/dermatology, as well as the AAD's website, which is aad.org. Treatment with the antifungal agent Terbinafine during pregnancy does not appear to increase the risk of major malformations or spontaneous abortions. This is according to the results of a large registry study in Denmark. The research comes as physicians have been generally reluctant to prescribe the drug during pregnancy because there have been such limited safety data available. The drug appeared safe during pregnancy in animal studies. The study was retrospective and nationwide in Denmark. It was published in JAMA Dermatology. In the study, researchers analyzed exposure to oral and topical Terbinafine and found no increase in the risk of major malformations or spontaneous abortions in exposed versus unexposed pregnancies. The authors did note that the study cannot exclude potential increased risk of specific malformation. That said, Dr. Jenny Moraes of the University of California, San Francisco, and her colleague, Dr. Mary Catherine Abel, said that to their knowledge, this study is by far the largest, most statistically rigorous study in the literature on this particular issue. In an editorial, they also pointed out that this study is a substantial contribution to a nearly absent literature regarding the use of Terbinafine during pregnancy. Indeed, according to Dr. Moraes and Dr. Abel, Terbinafine is possibly the safest antifungal available for pregnant patients. And finally, today, for pediatric patients with contact allergies, toys may be the problem. A variety of toys and other play products can cause contact dermatitis in children because of the nature of their ingredients. This is a finding from a review of 25 published articles that was published in the journal Contact Dermatitis. Researchers identified 25 articles describing dermatitis, rash, or eczema that was associated with a range of toy and play products such as video game controllers, putty, glue, dolls, games, cars, bicycles, slime, and electronic devices such as smartphones and tablets. The researchers report that nickel was the most common allergen overall. Cases of nickel dermatitis were associated with laptops, video game controllers, tablets, and cell phones. Phones were the most common electronics associated with contact dermatitis, which was observed on the cheek, periorbicular area, and the hand. There was one observed in the breast for a patient who kept her phone in her bra. Further, temporary tattoos have been associated with contact dermatitis in children, and so have homemade slimy products that often contain borax and contain other household detergents such as glue, shaving cream, or coloring. The researchers noted that a few limitations exist in the study, specifically the consideration of articles that were only published in English and only in cases of children. The consideration of children only eliminates other potential cases. Despite the limitations, the results suggest that clinicians should consider toys when they consider the cause of contact dermatitis among children, especially if the time to diagnosis is months or years. And now you're up to date in dermatology news. Remember, you can read more about any of these stories by clicking the relevant links in the show notes. The stories were written by MDH Dermatology editor Elizabeth Meshkati, reporter Jim Kling, and reporter Heidi Spleet. Coming up next, Peer-to-Peer with Dr. Vincent DeLeo. Welcome back to Dermatology Weekly. I'm the voice of MDH Podcast's Nick Andrews. It's now time for our peer-to-peer conversation with Dr. Vincent DeLeo.
Today we're talking to Doctors Nwanneka Okwundu and Stephen Feldman about adherence to topical psoriasis treatments. Can you both please introduce yourselves for our listeners?
Hi, I'm Dr. Okwundu. I'm at the University of Utah Department of Dermatology.
And I'm Steve Feldman. I'm a dermatologist at Wake Forest School of Medicine in Winston-Salem, North Carolina.
Great. We're so happy that you could join us today and take your time to discuss your recent publication. So let's get started. In your article, you state adherence to topical treatment for moderate psoriasis is poor in the short run and even worse in the long run. Can you explain this for us?
Yeah, so one day, something like 20 years ago, I was walking down the hallway at the medical center with my colleague Raj Balkrishnan, who told me there was a company that sold medication bottle caps that contained computer chips that could be used to record the day and time when patients took their medicine. And I was like, what? I had to find out what my psoriasis patients were doing. And so we did a little 8-week study giving patients salicylic acid to put on their psoriasis along with some topical tacrolimus. And we found that the first day we gave patients the medicine, they used it pretty well. And over the course of 8 weeks, their use of the medicine dropped by about 50%. I mean, it went down pretty quickly. In the short run, adherence is not great. And that was even in a study situation. Clinical practice is worse. Then, years later, we managed to get some fluocinolone in the bottles and give it to people with psoriasis and follow them over a year. And we found, as we did before, that in the first few weeks, the adherence drops off very quickly. And we found that over the rest of the year, the adherence stays poor. So that on any given day, somewhere between 1 in 5 and 1 in 10 people were applying their topical therapy.
That's amazing. Now, in the study that we're talking about, you looked at patients with psoriasis resistant to topical corticosteroids to determine if they would respond under conditions designed to promote adherence. Can you explain to us the setup of the study?
During the study, we promoted adherence by randomly selecting half of the study subjects to receive a phone call twice daily to remind them to use their medication. The other measure we took was to ensure adherence was to schedule frequent study visits, and there were 4 visits in total in the 2 weeks time frame. There was a visit at baseline, a visit at day 3, day 7, and at day 14. Another thing that may have helped with the adherence is the use of spray route rather than an ointment. Patients usually are more compliant when prescribed sprays rather than topical ointments. However, using sprays usually limits the ability to assess adherence directly in clinical studies because adherence monitoring devices for spray delivery systems are readily not available at this time.
So you did the study. What did you find in the cohort of patients who received the telephone call reminders?
Well, we found that most patients improved in all the measurement parameters, which includes the IGA PASI scores, the total lesion severity score, and the Paredes visual analog scale. However, the subjects who received phone calls showed more improvement in their disease severity than the subjects who did not receive phone calls.
Yes. Let me just add, I think while the reminders made a difference, the really important take-home message from this is not the telephone calls. It's that in both groups, patients improved. We took patients who supposedly failed topical therapy, and then we gave them topical therapy, and they got better. This idea that topical therapy doesn't work, I think, is based on a misconception. It's based on our observations that it doesn't work, but we're not seeing how poorly compliant patients are. If we take people who fail topical therapy and do things to really get them to use their topical medication well, their skin disease clears up.
Yeah, I was struck in reading your manuscript that the patients without the phone calls also did well, but they were being seen very frequently, and you were using a medication that was easy for them to apply. Would you agree with that?
Yes, it would be like if dentists gave you some kind of really easy-to-use floss and had you come into the dentist office every 3 days. People would floss like so well, I don't know, perfectly, but so much better under that situation than they do normally. If you tell people, here, floss every day, come back in a year, they don't do it. If you tell people, here, put this topical therapy on, it's messy, I'll see you in 3 months, it would be like, a piano teacher saying, here's a really complicated piece of music, practice it every day, I'll see you at the recital in 3 months. It's just not going to sound like a very good recital. So there's a lot we can do to get people to use their medicine better, a lot we should be doing, because making the right diagnosis and prescribing the right therapy is not our job. Our job is to get people well. And to do that, we have to make the right diagnosis, prescribe the right therapy, and do those things that need to be done to get patients to put the medicine on.
Yeah, I think that's really the key to this, and what I certainly learned from reading your manuscript. Now, we understand that in practice, most people can't see all of their patients every 3 days. So can you give us like an outline of what you would do, the two of you, with your patients to get them to be more adherent?
So other approaches that we can use as dermatologists to promote access to us by our patients are by organizing more like virtual visits or electronic interactions, like teledermatology, which is similar to a Skype phone call, giving the patients the opportunity to call from the office, email the physician. There are also some practical alternatives to help answer their questions and hopefully promote adherence. So besides promoting the patient's future access to the dermatologist, other approaches that can increase adherence are like encouraging the patient's participation in the treatment plan, prescribing the therapy consistent with the patient's preferred vehicle. Like if the patient prefers a spray, give them a spray. If they want an ointment, give them an ointment. They are more likely to use it that way. And extensive patient education at the time of prescribing the treatment might also help too if the patient really understands what their disease is and what the treatment is all about.
That's great. Stephen, other hints?
Well, we have patients with horrible skin disease, and they want their skin disease to get better. And they're motivated to use the medicine, and so we don't have to worry about poor compliance. Just joking. None of that's true. I get to work with the most motivated people on the planet, and you probably know who they are. Medical students who want a dermatology residency. And they come to work with me, and if they come to work with me for the summer, I don't give them a project at the beginning of the summer and say, work on this every day. I'll meet with you again in 3 months at the end of the summer. Because even these people, the most effective, most motivated people on the planet, would fail under those circumstances. I have a weekly lab meeting with them. And the lab meeting they think they're going to present to me makes them work all week. If I'm going to be out of town, I don't even tell them I'm not going to be there for the meeting, because if I did, they'd lose a week of work. So maybe we don't need to see people every 3 days, but we need to make sure patients realize we care about them, because they don't want to let us down if we have that kind of strong human relationship with them. And then we have to hold them accountable some way. You can tell them, I will see you back in 3 days, and then say, no, wait, then you're going to have another copay and have to miss work. I don't want you to do that. Let me give you my cell phone number. You call me in 3 days. Now, you don't have to answer your cell phone when they call. You don't even have to give them your cell phone. All that matters is they think they're going to call you. You give them your nurse's cell phone number. Or you could tell them, our EMR has this great portal now. Please send me a message in 1 week and let me know how this medicine is working for you. I really want to know. If you have new patients, maybe that you could get by with our standard way of telling people do this, come back in 8 weeks. But from this article, the take-home message is if you have a patient with resistant disease, at the very least, when you start them on the new medication, have them send you a message in the portal in 1 week to let you know how they're doing, because that will make them fill the prescription right away and use it much better.
I think all of those are great ideas, and Dr. Feldman has written many articles, and I think the one thing I take home from every time talking to him or reading one of his publications is that you have to make the patient believe that you care about them. And I think that's very important. And once again, it's a joy speaking to you, Dr. Feldman, and your colleagues here. And thank you for the article. Do you have anything else you want to add?
Okay, I just wanted to talk about other things to consider as the cause of the treatment-resistant or poor outcome if the patient does not respond as expected after doing everything possible. So we may want to consider the possibility of an error in the diagnosis, resistance to the prescribed treatment, a concomitant infection or irritant exposure that kind of worsens the disease and needs to be addressed. And in case of biologics, we might need to consider anti-drug antibody formation.
And the one thing I would add is that when we're talking about psoriasis patients, I would encourage them to join the National Psoriasis Foundation. This is a very efficient way for you to educate patients about all their different treatment options. And the Psoriasis Foundation encourages patients to listen to their doctor's advice.
So I want to thank both Dr. Okwundu and Dr. Feldman for being with us today and taking their time out of their busy schedules. And I refer everyone listening to their article in Cutis. Thanks again, guys.
And that's it for this week's episode of Dermatology Weekly. Don't forget you can find previous episodes wherever podcasts are found. Be sure to catch every new episode of Dermatology by subscribing on Apple Podcasts, Google Podcasts, or wherever you like to listen. Dermatology Weekly is produced by MD Edge editors Elizabeth Mashkati and Melissa Sears. The peer-to-peer portion of the show is hosted and produced by Dr. Vincent DeLeo. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.